Hello everyone. In this particular video we would be taking a look at septic abortion. This is quite huge. I think it is for a 10 marker. Yeah, so let's begin. Here the first one, definition. Septic abortion is any abortion complicated by infection of the uterus and its contents. So infection of uterus and its contents. It is often associated with unsafe abortion practices and can lead to serious maternal morbidity and mortality if not promptly treated. So it is associated with these things, unsafe abortion practices, and which can lead to, as we all know, sepsis, can lead to serious maternal morbidity and mortality. And coming to the incident, should we go through this? It's fine. Anyways, it's going to be a long video. 10% of the abortion requiring hospital admissions are septic. The majority of the septic abortions are linked to incomplete abortion. In most cases, it's the practices and lack of aseptic techniques which are the primary causes. Coming to the mode of infection. So, the organisms responsible for septic abortions are typically those found in vaginal flora. They may gain access to the uterus through endogenous or exogenous route. Sources. The sources could be these. The infection remains localized to the uterus, so that is one. Other one is introduction of pathogens via non-sterile instruments or unsafe abortion practices. So this is one which is localized to the uterus. Other one, it is introduction because of these practices. So the practices being, so when whatever we are talking about over here, in most cases this is the thing that's happening. Introduction of pathogens via non-sterile instruments or unsafe abortion techniques. What are the organisms, microorganisms that are involved? So there are anaerobic, aerobic and mixed. So anaerobic, Bacteroides fragilis, Clostridium welchi, and anaerobic streptococci. And coming to aerobic, there is E. coli, Klebsiella, Staph aureus, Pseudomonas and Group A strep. Coming to mixed infections, often include MRSA. So that is so those are the organisms. So the most common ones, I will repeat again: anaerobic, Bacteroides fragilis and Clostridium welchi; aerobic, E. coli and Klebsiella and Staph, Pseudomonas; mixed infection, MRSA. So that is done. Coming to pathology, so 80% of the cases infection is localized to the uterus without spreading into the myometrium. So only to the uterus, innermost part. Innermost meaning the surface level. 15% localized endometritis surrounded by protective leukocytic barrier, but may spread to parametrium, tubes or ovaries. So it is like let me show a diagram. Parametrium. With this we would be able to see the rest of the things too. So this is for a different image, but overall this is the region and it's localized to this region in 15% of the cases. This particular thing, septic abortion, the sepsis, the infection. In 5% of the cases, it goes entirely haywire, where there is generalized peritonitis and endotoxic shock. Coming to the clinical features, so based on the severity and extent of infection, it would vary. So coming to general symptoms, the woman appears sick and anxious, chills and rigors, suggestive of bacteremia, persistent tachycardia which is greater than 90 beats per minute, hypothermia or fever. So both, either of these. So where else did we see something like this? It was in case of neonatal sepsis, where both could be there, hypothermia or fever, abdominal pain or chest pain. So these are the things. So specific signs: offensive vaginal discharge, purulent or bloodstained. So with that we know there is something bad going on down there. Pelvic tenderness and boggy feel in the pouch of Douglas, suggesting pelvic abscess. So we know where the pouch of Douglas is, between the uterus and the rectum, the pouch. Don't have to show the diagram, it is, everybody knows about it. Diarrhea, vomiting and mental confusion in severe cases. So these are the specific signs. So one is offensive vaginal discharge, pelvic tenderness and boggy feel in the pouch of Douglas, diarrhea and vomiting and mental confusion in severe cases. Coming to the clinical grading, grade 1, grade 2, grade 3. Grade 1, infection confined to the uterus. Grade 2, infection spreads beyond the uterus to the parametrium, tubes or ovaries, sorry about it, maybe I should stop using this. Yeah, I'll stop using it. Parametrium, tubes, ovaries or pelvic peritoneum, grade 3 generalized peritonitis or endotoxic shock. So these are similar to these. So 18, 15, 5, 80, 15, 5. So confined to the uterus, beyond parametrium, tubes, ovaries, pelvic peritoneum. Pelvic peritoneum was not a part of this. Maybe it is. Yeah, so there is here also there is protected by, surrounded by leukocytic barrier. That is one thing. Yeah, so generalized peritonitis or endotoxic shock is the last one. Coming to the management, management, where we talk about investigations first. So there are routine investigations and special investigations. So routine, blood test, urine analysis, cervical or high vaginal swabs. So the first one, hemoglobin or total TLC, DLC, ABO, RH. So with this we get to know, have an idea about the anemia, like in this specific case schistocytes, something DIC in that sphere. TLC, DLC, ABO, RH. Urine analysis includes culture to identify urinary tract infections. So culture, cervical or high vaginal swabs for Graben staining, culture and sensitivity. Same thing. Here it is urinary, but here it is specifically the genital tract. Coming to special investigations, there is USG, pelvic abdominal, blood culture, serum lactate, coagulation profile, plain X-ray, abdomen or CT. So USG to detect intrauterine retained products of conception, pyometra or free fluid in the peritoneal cavity. So that is one. Next one is, especially if there are, second one, blood culture, especially if there are chills and rigors. Serum lactate, so a greater than 4 millimoles suggests tissue hypoperfusion and sepsis. So lactate and coagulation profile to rule out DIC as mentioned earlier. Plain X-ray, abdomen and chest, abdomen for suspected bowel injury, chest to identify pulmonary complications like atelectasis or ARDS. Coming to complications, if you don't treat this in this particular thing, management, it's supposed to be treatment, but it's fine. Complications, we'll look at that first, then go to the treatment. Immediate or late. Immediate, there is hemorrhage, uterine perforation, endotoxic shock, generalized peritonitis, and late there is CPP. This one is, I haven't still added the answer yet. I need to. It is somewhat important, not whole lot, but I need to add the answer to that. Ectopic pregnancy is something else. Secondary infertility, menstrual irregularities. So first one, hemorrhage due to uterine trauma or incomplete abortion. So that is one thing. Next one, uterine perforation. I'll stop doing that, otherwise. Uterine perforation or injury to adjacent organs. Endotoxic shock caused by E. coli or Clostridium welchi. Generalized peritonitis due to infection spread. Then coming to late complications, CPP, chronic pelvic pain or dyspareunia. So that is pain during coitus. Ectopic pregnancy due to tubal damage. So this is late. These are late. Chronic, right? Chronic. Ectopic is like it's not supposed to happen immediately. Maybe few days down the line, few weeks or months. Secondary infertility due to blockage, strictures and all form, menstrual irregularities and pelvic abscess formation. So that is the final late complication. Coming to the treatment, so it is mandatory hospitalization, and what does it include? Infection control, evacuation of uterus and supportive therapy. Coming to general management principle, then there is antibiotic therapy, evacuation and supportive therapy, and there is also surgical intervention, and then we also talk about prevention. So first we look at general principles of management. So number one, control the sepsis. Start broad spectrum antibiotics immediately, then remove the source of infection, evacuate retained products of conception. Next one, supportive therapy, correct hypovolemia, electrolyte imbalance and organ dysfunction. So this one, controlling sepsis, what do we do? Antibiotic therapy, grade 1, there is grade 1, we learned different grades. One was restricted to uterus, other one was surrounding the uterus, parametrium and all that. Finally there was peritonitis and all. Grade 1, antibiotics, start empirical therapy targeting both aerobic and anaerobic organisms. That is one. Grade 2-3 antibiotic therapy, antimicrobial therapy, there is piperacillin, tazobactam or carbapenems with clindamycin IV. Then comes vancomycin or teicoplanin for MRSA. So we know drug of choice for MRSA is vanco. Next one coming to gentamicin, 3 to 5 milligrams per kg single dose. 3 to 5 milligrams per kg single dose if renal function is normal, because we know aminoglycosides are renotoxic. Yes, like they are toxic to the kidneys. Yeah, metronidazole to cover anaerobes. So we piperacillin, tazobactam or carbapenems with clindamycin, vancomycin or teicoplanin for MRSA, gentamicin if renal function is normal, metronidazole to cover anaerobes. Then prophylactic anti-gas gangrene serum administered if clostridial infection is suspected. So with this we have covered the antibiotic therapy. Next, coming to evacuation of the uterus. So even here there is grade 1, 2, 3 and surgical procedures. So surgical there is separately also. Yeah, so grade 1, performed evacuation within 24 hours following antibiotic therapy. This one, then after 24 hours do the evacuation in grade 1. Grade 2, 3/3, delay evacuation until infection control is achieved unless there is excessive bleeding. So delay evacuation, like first control the infection in grade 2, 3 because it's a lot, right? You want to control it, then start with your evacuation, or else do the evacuation only if there is excessive bleeding. Coming to surgical procedures, there is G&D or surgical or suction evacuation, dilation and evacuation or suction evacuation, posterior colpotomy for pelvic abscesses in pouch of Douglas, posterior colpotomy. Yeah, supportive therapy. So it is a septic issue, septic shock kind of a thing. So what do we need to do? Fluid resuscitation, administer IV fluids to maintain hemodynamic stability, blood transfusion to correct anemia and coagulopathy. ICU management required for multi-organ dysfunction, shock or ARDS, organ dysfunction features, persistent hypotension, oliguria, coagulation abnormalities, hyperbilirubinemia, thrombocytopenia. So yeah, coming to finally surgical intervention, laparotomy indications, uterine injury or bowel perforation, septic shock not responding to conservative treatment. Then aseptic techniques are ensure sterile condition, like we need to make sure that sterile conditions are maintained, and post-abortive care, provide post-abortive abortion counseling and follow-up. So it happened pretty quick. Yeah, it's fine. Anyways, it's not given much in the textbook, so I think maybe it's there, but it is like compressed notes kind of a thing, right? So it is actually easily understandable too, and you can write something. Yeah, so with this we come to the end of the topic of septic abortion. In case you like this particular video, you can like it. In case you have any kind of suggestions or corrections, you can send it or you can write it in the comments too. Okay, bye bye.